let me give you an idea of a patient who comes in who has, let's convert this into completely different part. Okay? So let's do approach first. Okay. So your patient who comes in was driving on the road at on the highway. He was at 100 kilometers per hour speed, and another vehicle which is also at 100 crashed him. Okay, and now he comes to your ER, and they quickly move this patient into the ICU because the patient had hypotension. Okay, now you have done a complete clinical examination. And all that you can find is a kind of a seatbelt injury on external examination. But the patient's blood pressure is 80. Patient has come in. Okay, now you are the person on duty. I am at home. How will you approach this patient? The patient's blood pressure is 80. One of the slides mentioned that if the blood pressure falls, there is a blood volume loss of more than 30%. Right? So this means to say that he is bled because there is nothing else happening here. There is something else happening. The hypotension is occurring. That means he is severe, he is critical. He was driving as a normal patient who has had an accident. So you are apart from your resuscitation that is going to be there, apart from all the ABCs and resuscitation you are going to do, how do you approach this patient? What do you do? The first thing, what should come to your mind? What should come to your mind? How to diagnose problem here? What is the investigation you want to do? Ultrasound. The first thing you want to do is an ultrasound. The first thing, I'm not going to think too much. If a patient comes in, there is drop in blood pressure, the first thing in my mind is ultrasound. For that matter, even in ICU. Even in ICU, if you have a patient whose blood pressure is on the lower side, the first thing in my mind should be ultrasound. The first thing in my mind should always be ultrasound. Not starting NOR and that is okay, that goes on, but you have to figure out why. So the first thing comes to your mind is ultrasound. That is how you should think. Your thinking should be, patient has come, BP is 80, 30% blood loss, I need to find out whether BP is what's happening. Why the blood pressure is low. Okay, so the only indication is that there is a seatbelt injury, then the injury would be anywhere here, in this area. Because you are not seeing an external wound, you are not seeing the leg broken, you are not seeing the femur broken, you are not seeing those things. That is, you can figure out with your examination. When you do a secondary survey, you can figure out there is nothing down there. Spine you examine, there is nothing there. But there is a blood pressure on the lower side. This is that classical patient in which, going for a CT becomes very difficult. At 70 systolic and 80 systolic, they will move the patient to ICU. They will come to the ICU. Okay? Or they will call you down, case ka BP kya karna hai? You must understand that in a case like this, if you give fluid, the BP will not come up also. Because he is bleeding. Or he has had some other problem. So how do you go with the fast? So what he said is absolutely right. I will go for an ultrasound examination. So how do you do this? How do you progress in this? So which are the views you want to use? So this is very essential. It's very essential because this examination should be complete in 3 minutes. 2 to 3 minutes it should complete. In 2 to 3 minutes should complete. That means you should have a way that you are going to do all your life. In every patient in the ICU you should have a way to do it. If you notice, I have a way to do things in ultrasound. That way is used everywhere, in trauma, in resus, in echo, in everything. It is the same technique that you use. That's why as an intensive care doctor, you should have the same technique that you can reciprocate when there is a severe injury. You can't just keep doing things and try to figure out what's happening. You understand? You should have a way. So what is the first ultrasound probe and where will you place it? Yes. Now why is that so? You're right. Why?
Temporal ruler.
You have to rule out something in the heart. Now, what is the views you will use and what do you want to see in the heart?
I want to rule out a transfer or pericardial hemorrhage.
So there are 3 views you must use. Always. There are at least 2 views. One is the parasternal long axis. Okay. And you have to use the parasternal short axis and you have to use the subxiphoid axis. These 3 views, which are normal views that we use in the ICU, should be immediately used. So the mnemonic for the rush exam is the high map, where H is heart. Okay, the mnemonic is high map where H is heart. So in the cardiac ultrasound, when I am placing my probe, in the long axis view, I am looking for what? What am I looking for? How does it look? Yeah, so correct, between the descending aorta and the heart, you will see fluid, you will see black. If that is the case, there may be tamponade, there may be tamponade. What else am I looking for here? What else am I looking for? I am looking for systolic heart failure as a part of hypotension. Whether it is an MI, you understand, whether there is an MI, systolic heart failure, that means ejection fraction going down. Are you understanding? So in the long axis view, my thinking is very clear. In the long axis view, I am going to look for that blackness between the aorta, descending aorta and the heart, and I am going to focus my M mode on that mitral valve to look for EPSS or it's called EPSS. Next time, go to the ICU, do the EPSS and find out the mitral valve expression. Okay, EPSS. Go look at the EPSS there. Okay, not mitral valve actually, aortic. Okay, so the EPSS, I'm going to look at the EPSS there. So I'm going to look at that and give a kind of an idea about the left ventricle. Alright, with this view. Then the next thing I'm doing is a short axis. Why am I doing a short axis view? What will you see in a short axis view? You will see the left ventricle. That's the contractility of the left ventricle. What else you will see in the short axis view? I will see a D-shaped ventricle. When I have a D-shaped ventricle, what does this mean? Normally, how does the short axis view? You will have round ventricle, left ventricle, and a kind of moon-shaped right ventricle. You will have a round ventricle and a moon-shaped right ventricle. Okay. When I have this right ventricle pushing the left ventricle becomes like a D. The left ventricle becomes like a D. When does this occur? When there is pulmonary embolism as a cause of your hypotension. So, as a cause of your hypotension, because this is ET systolic, okay, there is going to be changes. So, pulmonary embolism as a part of your hypertension. Yanika, you missed this out completely during your patient. That's what I'm telling you also. When you have that patient yesterday night, you should have done the rush examination and told me the problem looks like pulmonary embolism.
Yes.
You are understanding, if you follow a protocol, the way you are supposed to do, not my own protocol, not somebody else's, it is a established way of finding out hypotension, established way of doing hypotension, ultrasound, examination, is you are supposed to follow it, you will get the answer. You are not doing it the right way, that's why you are not getting answers. Because I did that, when I came I did that and immediately I got the answer. I didn't need a cardiologist to tell me that. Because I don't need to be a cardiologist, I need to be simple, doing the same protocol all the time, you will get the answer. Okay, so when I look at the long axis view, I am looking at systolic function, I am looking at cardiac tamponade. When I am doing a short axis and an apical 4 chamber, I am looking at what? I am looking at global. I am looking at the global systolic function and I am ruling out pulmonary embolism. Why these two views? Because in short axis view, I will see D-shaped left ventricle, and in the apical 4 chamber view, I will see the left ventricle equal to the right ventricle. Ideally, the right ventricle is 2/3 the size of the left ventricle. That is, it's smaller, much smaller than the left ventricle. If you find it equivalent, what am I looking at? It is possibly some kind of pulmonary embolism in the absence of long-standing COPD or asthmatic or lung conditions. Are you understanding? Third thing what I'm going to look at when I'm looking at the apical 4 chamber is a hyperdynamic system. That means the whole heart is contracting, relaxing. The entire ventricle is kissing and going back. Kissing and going back. What does this say? This may not be pulmonary embolism. This is loss of blood. This is blood loss, active blood loss. The ventricles are empty. This is most probably looking at ventricles being empty because of loss of volume. Are you understanding? So in my heart examination, I have now ruled out very proximate causes for hypotension. One is cardiac tamponade. Second thing is pulmonary embolism. Third thing is systolic failure. And fourth thing is blood loss. I have already in my first 4 views, I have already seen these 4 things. Okay, so yesterday when this patient dropped blood pressure, what should I have done? I should have first done this. I should have seen what is the cause of my hypotension. Are you understanding?
Sir, I did actually RARB dilated.
So
but
what
I
you are
didn't
supposed to
feel
do, the whole thing is supposed to do, tell me, Arey, this is PE. The problem is this. Are you understanding? You got the point. All 4 views. By doing one view, I will not have a complete answer. What I am trying to tell you is, it has to be complete examination. When you do a complete examination, you will have a kind of an answer as to what the blood pressure. This is not 100% sure also. I have to do everything. I have to do everything to be a little bit towards my diagnosis. Are you understanding? So if I want to find out the cause of hypotension in any patient in the hospital, the first examination will always be heart. In that heart, I need to do parasternal long axis, I need to do parasternal short axis, I need to do a apical view, 4 chamber, and I need to do my, if I cannot do all these things, I will do my subsequent view. Clear? And what I am seeing in that, now you have understood? The things that I am seeing in that? So that this is only the heart examination. Why is it important to do a subxiphoid or a parasternal long axis is also to the fact that in the event that you get a pericardial tamponade, that ultrasound gives you the direction of your needle. It has to be done immediately, this patient can arrest. That is why the first thing that we do in these cases is always heart. Clear? That is the first thing. So these are immediate dangers. Cardiac tamponade patient can die. I need to put the needle quickly. That is why my first thing is heart, and I am not looking at IVC and lung and all. Are you understanding? My first immediate problem that if I don't heal, patient will die is heart. Especially when I have a seatbelt injury, blunt trauma. Now we go back to the blunt trauma patient. If the blunt trauma patient comes to you, the first reversible pathology that I have in my hand is
tamponade.
The fastest reversible and the worst prognosis is in the cardiac tamponade, which if I don't treat, this patient will die. Clear? What is the next thing that you want to do after the heart? IVC. The next thing you do is the IVC. Okay, why do you want to do the IVC now? So let's ask, if I would ask you the question, why do you want to do the IVC? What data are you going to get from the IVC? So how do you do the IVC? It's IVC slide. You keep the probe absolutely perpendicular with the marker facing upwards and slide it towards the right side. Slide it towards the right side. You keep the IVC marker facing upwards and slide. Then you have to do this every day. Every day if you do it, follow the same pattern, your ultrasound will get over in 4 minutes. 3 to 4 minutes ultrasound is done. And you have got loads of information. Okay. Now, what do you want to do the IVC for, Ruchika, if I ask you? This is a case of hypotension. What am I looking for when I am having hypotension in the IVC? What should my eyes use? Your eyes will see only what your mind can think. Okay, others will not understand what am I looking for? Sachin?
Dilated.
Yeah, so if it's dilated, what does it mean? This patient has got hypotensive, patient has had a trauma, and he's in the ICU, and the IVC is dilated. What am I looking at? ये तो गाड़ी चलाते चलाते पानी तो नहीं पी रहा था वो, ऐसा भर के 4 लीटर पानी तो नहीं पिया वो. What am I looking at? What am I looking at? Pulmonary embolism, cardiac tamponade. 2 things I'm looking at. I'm looking at cardiac tamponade and pulmonary embolism. When the IVC is dilated and non-collapsible, I have started thinking this way. In this particular patient, what have I started thinking? Is there a pulmonary embolism? Is there a cardiac tamponade? I'm not looking at fluid status here. There is no indication to look at fluid status. Oh, other way around, if the IVC is completely collapsible and the size is less than 1, maybe this may be a patient who is bleeding. Maybe this is a patient who is bleeding. That's why the IVC is small and that's why it's extremely collapsible. What will that, how do I know that this patient is bleeding? I will see 2 things in this. I will see that the IVC is collapsing and very small and the heart is hypercontractile and kissing each other. So now I am kind of reasonably going towards that. It is still not right. I am still just looking towards this. You are trying to put all your details that you are getting from your examination and coming to a conclusion as to what I am dealing with. Clear? So always remember the high map. The first thing was heart. The second thing was IVC. What is the third thing? What is M?
Morrison's
Morrison's plot. What is Morrison's pouch?
Hepatorenal
Hepatorenal space. Now, why is that space so important?
Collection of
That's
fluid.
the first space.
If there is
Fluid
a intraperitoneal.
Yeah, in a supine patient, the Morrison's pouch is the first place. The Morrison's pouch, also called as the hepatorenal recess, that is the space between the liver and the kidney. That space is the space where the fluid will first get accumulated. But what is the problem with the Morrison's pouch? You can see fluid accumulated only when it is close to 500 ml. Okay, so it doesn't rule out that this patient has suffered or not suffered a blunt injury. Are you understanding? Because it needs close to more than 250, at least close to 300 to 400, 500 ml that you require for that space to have blood, and it will be black in color. If that space is there, it is not black but it is white. That means what is it? Chronic. Patient has come a while later. Patient has had a bleeding. Then you have seen it has become white. It means clotted blood आ गया है वहाँ पर. So a paracolic cutter say the closest place where the blood goes is the hepatorenal space. And to see the hepatorenal space, I need to see the caudal margin of the liver, I need to see the lower pole of the kidney, and I need to see the entire hepatorenal space. The other space that I want to use is subhepatic space. Subhepatic space. That is, thoracoabdominal trauma can have bleeding above the diaphragm. Clear? By the way, which is the common organ that is injured in the blunt trauma? Which is the first organ to be injured?
Spleen.
It's always the spleen. So the next thing that we're going to look at is spleen. So in spleen, what do you look at? So in Morrison's pouch, we're looking Morrison's. So when you say Morrison's, we are also saying spleen. Spleen and pelvis. So spleen में क्या देख रहे हैं हम लोग?
Splenorenal recess.
Sorry?
Splenic rupture and splenorenal recess.
So what are you going to look? Spleno?
Renal.
What is the importance of splenorenal recess? Never. So fluid doesn't accumulate there. Unlike hepatorenal space, fluid doesn't accumulate in the splenorenal recess because there is a ligament, a splenic ligament that attaches to the renal. Lenorenal ligament is there, which prevents the fluid from actually accumulating in the splenorenal recess. So it is very difficult to figure out whether there is a splenic trauma. Okay, very difficult to determine whether there is a splenic trauma because there the fluid, if it is hypotensive, the blood is leaking, the blood will be above the spleen. Somewhere above the spleen. You understand? Subdiaphragmatic in the splenic recess. So around the spleen you are supposed to search. It's not in the splenorenal space. Are you understanding? So if fluid doesn't accumulate there because of the lenorenal ligament, there is a problem with the spleen. Are you understanding? So you need to see around the spleen, especially above the below the diaphragm and above the spleen. Okay, it's important to see the lower pole. That is why I see the spleen 100 times. If you see the spleen every day, the day there is a trauma and there is a fracture of the spleen, you will be able to understand that there is spleen trauma there. You understand? So we have finished Morrison's pouch. We have finished splenorenal. Okay, recess. That is the right upper quadrant and left upper quadrant. And then comes the pelvis. Okay, so when I say Morrison's pouch, I am saying Morrison's pouch, right upper quadrant, left upper quadrant, and pelvis. In the pelvis, what am I looking at? The recto pouch of Douglas. Okay, or the rectovesical pouch. You have to look at that place to see for fluid. Look at that place to see for fluid. Right? Just put your probe, you will see the space. Next time, please do it. Because when you have to do it, you will never understand otherwise. Okay, do it. Look at normal. Look how the normal, normally that pelvic space looks, how it looks, you must understand that. Okay, so pelvic, see you all are so many 3 people in one ICU here. I was single person and I should still work like this. I should do it continuously on all my patients. Because I have to understand, my thinking was 10 साल के बाद I don't want to go and understand now. I have to understand from that time. You understand? हम लोग के पास एक अल्ट्रासाउंड पूरा हॉस्पिटल में होता था. You are having an ultrasound near ICU. I mean, I don't know why you all are not looking at all. You should look all these things. You should be telling me like this. All of you are exam going. You have told me immediately. I am surprised why you are not able to tell all these things. Because this is something that you do throughout the, so you have a case of trauma and I ask you a rush examination and you don't know what is a rush examination or a pass. How can I pass you? Are you understanding the issue? Because this is standard of care. It is not something must be fantastically terrific. It's some simple standard of care it is. Are you understand what I am saying? In a standard of care, if you cannot answer, I cannot pass you. What is the issue? And it is right also not to pass, no? Because if a ET systolic comes to you, don't know what to do. It is not right, no? Isn't it? Huh? So, okay. So then you have the Morrison's pouch, you have the sphenorenal recess, and you have the pelvic. So the HI ho gaya, M ho gaya. What is A? Aorta. So how do you look at the aorta? How do you look at the aorta? Put the probe, look subdiaphragmatic, suprarenal, infrarenal, and below infrarenal. 4 places you are supposed to look at. Huh? Okay, just before the bifurcation of the iliac, that is infrarenal, then infrarenal, suprarenal, and just below the diaphragm. You are supposed to do this from top to down. You are supposed to go 1, 2, 3, 4. As you span it from top to down, you will see this is suprarenal. You will find the renals. Then you will go down infrarenal. It will go near just before the bifurcation of the iliacs. Aorta. What are you going to look at that? What are you worried here? You have a patient with systolic. What are you worried? What are you worried? Dissection. You are worried about dissection. It's not an aneurysm. Suppose you are looking at all these things. So what will you see there? The size of the aorta will become larger. So anything more than 3 is scary. A normal is 1.5. Anything more than 3 is scary. You are looking towards dissection. You are looking towards aneurysm rupture. Things like that. What are you looking at? Okay. So aorta. Clear on this? 4 places of aorta you have to look at. These are the 4 places that you are supposed to look at. You can't just look at one place. Okay, subdiaphragmatic, suprarenal, infrarenal, and just before the iliac bifurcation comes in. You will see this only when you actually scan it. You have to scan on every patient. So you may not see it on every patient. This is just corroborative. You may not see it on every patient. That's why if you see it on normal, you understand where to see it at least properly. Hello? P is pulmonary. Then comes pulmonary. In pulmonary, you follow this protocol, which just now you just now taught. In that, what am I looking at? The 2 important things in pulmonary is sliding. If there is sliding, reasonably pneumothorax is out. If there is sliding in all the 4 quadrants, pneumothorax, which is the cause of hypotension, is reasonably out. You understand? What you can do? Put the probe, put M mode. Put the probe, put M mode. Put the probe, put M mode. What do you see? If there everywhere there is sandy beach appearance, there is no pneumothorax. If there is sandy beach appearance, there is no pneumothorax. The moment you get stratosphere sign, there is something there. There is something there. Clear? Are you clear? I don't want to look at pneumonia and all these things here. I want to look at only pneumothorax, because that is the cause of your hypotension. Okay. Now, if there is no history of trauma, the next thing that you think is look of ectopic pregnancy. That is the last thing you look at. If there is history of trauma. Okay. But otherwise, classically, should be the high map ED. Okay, high map E basically. Okay, and D is last is DVT. When you want to extend the high map mnemonic, rush examination, you can say high map ED. So in ICU, you should do high map ED. Okay, high map ED means heart for all the 4 to find out why. I, IVC, M, Morrison's pouch and sphenorenal recess at the pelvis. A, aorta. P, the lungs. E is going to be ectopics, that is pelvics, and D is DVT. So there is nothing that you don't know out of this. Apart from aorta, I think you know all of these. If you put all of these together and use it on every patient of hypotension, you can make a reasonable map. Okay, this is what the problem is probably. Because I am finding this. Are you understanding? You cannot do one examination and say I have this problem. You understand? I can't do just the lung and say this is the problem. I can't do just the heart and say this is the problem. So in that particular patient, what we should have done? Okay, I have seen the heart, the RV is equal to the LV, the IVC is dilated. I am not finding, the lung marking sliding is very good. I don't find vasodilatation. The heart is not hyperkinetic. This is something with respect to obstruction. If it is not pneumothorax, this has to be pulmonary embolism. And you would then do a Plapp's point to figure out whether there is pneumonia there. That solves the entire problem in this patient. Are you understanding? Of course, rush examination comes when the patient is exsanguinating in front of you. There is hardly 2 or 3 minutes. He is dying in front of you. You need to rush them into the operation theatres if they have something like this. right? At this current moment, you don't get such patients because what happens is the patient is already 120 systolic, you go for a CT and everything is clear. Everything is clear. You will be using the rush ED for your hypertensive patients that are in ICU. You may not use it for trauma. Are you understanding? You may not use the rush examination for trauma because you may not see such patients. Whereas if you are working in science trauma or you are working in say on the highways, you will see this. Where you have to do a rush ED which will give you an answer that if you don't go inside, patient will die. Okay. Earlier we used to do something called DPL, diagnostic peritoneal lavage. What is this? We explain what is this.
Sir, inframedical, then linear alpha we have to dissect and that needle is there.
No. So you put a tubule inside. You put something like an ICD inside. You dissect near the umbilic, below the umbilical, safest spot to dissect. You take a tube, put it into the pelvis from top.
ICD of small.
Like an ICD or a smaller size ICD. Put that inside. Pass 1 liter inside. Take that 1 liter out. And then you monitor the WBC and RBC. And if the RBC is more than a lakh, it is positive for abdominal trauma, blunt abdominal trauma related emergency shock. Understand? We don't do this anymore. हम लोग नहीं करते आजकल because अपने पास rush आ गया है, rush आ गया है, fast आ गया. We don't need to do this anymore. Because you just imagine if you're going to put a tube inside, take out from there, send it to the laboratory, they will read it and then they will tell you. It is not possible. वो उतना time है नहीं हमारे. This was done at the time when there was no ultrasound, when there was no CT scan. I have done it many times. When I was working in science, I have done it many times. But it used to be horrible. We used to never do that. We used to try to search for blood by putting needles here and there. It doesn't make sense. We were very badly incapacitated because we didn't have all these things. Now we have all these things which makes life very simple. Clear on the rush ED exam? So next time when you are having a hypotension in the ICU now, don't just relate it like that. At least once during your 8-hour shift, look at that rush ED exam. Okay, and then you generally know this patient is going down because of sepsis. You generally know it because this patient as you have been following it up. But with the rush ED, you will confirm this, and then next time you want to really figure out, it is easy for you to do it. Are you understanding? हमारे पेशेंट में ऐसा डायग्नोसिस नहीं है, ऐसा होता नहीं है. हमको डायग्नोसिस मिला हुआ रहता है. But when you are like in the case that you had, you were not able to give me a diagnosis because you didn't know how to do a rush ED. Are you understanding? So next time if you do it regularly on your patients and you already have a diagnosis, you are confirming your diagnosis. So next time you don't have a diagnosis, you do the rush ED, you get the diagnosis. It's a very simple examination. If you ask me, it's a very simple examination. How much time it takes? Not more than 3 minutes. It doesn't take more than 3 minutes to finish a rush examination. It doesn't take more than 3 minutes to rush examination. If you see, I do it every day. If I have to do an ultrasound myself, I don't just do ultrasound of one area. I do the whole ultrasound, no? Because I am trying to put everything together and figure out, okay, this may be this. None of this single examination is confirmatory for anything. Nothing. Clear?